Hi, I'm Dr. Eric DeYoung, Chief of Geriatrics at Capital Caring Health. So at Capital Caring Health, we chose to try to build a home-based primary care program starting January 2020 in what previously was mostly a hospice and palliative care organization. What we found really exciting is to combine the clinical and financial strengths of those two models, primary care and kind of hospice, into one kind of clinical and business operation. The benefits of doing that are there are many staff, and the mission of Capital Caring Health is devoted to advanced illness care, which is similar to primary care at home programs. But we're neither a hospital-based program nor a freestanding program. And we're neither just fee-for-service nor just per diem. We have to combine the clinical services like the medical staff, the social work that's critical to both, nurse practitioners who may be able to do both, say, face-to-face for hospice, but also primary care, as well as tap into the volunteers and outreach who are present in the hospice organization. The financial strengths of each are complementary. In primary care, you can do a lot of fee-for-service billing, including direct and indirect codes, which are now available from Medicare. And you can tap into population-based, value-based payments, which are coming out of CMS and Medicare Advantage plans. Whereas hospice brings a tremendous financial strength of a solid daily per diem payment for each hospice patient, which is a great engine for the overall organization. So clinically, we work together when patients get to the end of life and really try to then tap into the relative skills and complementary strengths of the different clinical members. A final big challenge of the kind of integration is changing the culture of what is primarily a hospice organization. This has been really good for both the hospice side and the primary care side. We're learning a lot about how to take care of people at the end of life, and the staff who are thinking more about end of life care are learning to take care of people upstream for years before they get to the end of life. And the culture change has to occur at both the clinical level as well as at the business and operational level. So we had to adapt to COVID-19 in many ways, most importantly for the patient and staff safety. And we chose to use universal precautions for both the staff and the patients in terms of gloves, masks, goggles for the staff, and masks for patients and families when they're in the same room. We tried to balance in-person and telehealth visits so that there was those important in-person visits that we still did under safe precautions, stay in close touch with our patients, and make sure they still had access to specialists in a hospital for their other illnesses other than COVID-19. We also trained some of our clinical staff, both nursing and NP, to do COVID testing wherever it was necessary, so we could diagnose and treat folks at home or on the hospice side with COVID-19 or to rule out COVID-19. We then thought a lot about how to use televideo and do the billing and coding, and Linda's going to talk about that.
Hi, I'm Linda Biedrzycki. I'm the Vice President for Practice Management at Capital Caring Health. As Eric mentioned, we rolled out telehealth visits, televideo with a lot of our patients, and telehealth actually offered a lot of flexibility with our care model. One of the things that we learned is that it's really important for us to plan ahead for the challenges with telehealth, particularly with our elderly patient population. Luckily, we've been able to work closely with our patients' caregivers and facility staff for those who live at the assisted living facilities to facilitate some of the telehealth visits. With regards to billing and coding, it was very challenging with all of the new CMS regulations and having to stay on top of the regulations as they changed and know which billing and which codes to use. And so we found that it was very important for us to have frequent communication with our medical staff and really condense the new coding regulations in an easy to read format, an easy to understand format for our medical staff so that they could do appropriate coding and billing.
The future for our primary care at home program, which is the name we've given it here at Capital Caring Health, is that we now have learned both through COVID-19, but also from starting a program from scratch in a hospice organization, that we can probably expand our geography faster than we initially thought. We can use the existing staff, both hospice, palliative, and primary care, with telehealth to serve more zip codes than we originally thought possible. We're going to try to find the right balance of in-person and telehealth so that we do those important new visits or urgent visits where people are unstable, where you need to be there in person, but use telehealth and televideo to expand our reach. We've also learned from a business and financial perspective that we need to really have a good proportion of our patients in senior living communities as well as individual homes so that we can have more efficiencies of scale, and think a lot about diversity of payment and revenues. And Linda will talk a little bit about those kind of other payment models that we can take advantage of in addition to fee-for-service.
So as Eric mentioned, we've learned that it's important to diversify our revenue sources. Fee-for-service is just not enough these days. And so we're at Capital Caring Health, we're actually working on establishing some medical director contracts and other partnerships with senior living organizations. And we'll be actually participating in new value-based payment models such as direct contracting starting in 2021. In addition, we've also learned that geriatric physicians are scarce and that we need to modify our staffing model to include more nurse practitioners, nurses, and community health workers. And so as we move forward and continue to grow our program, we'll be looking at ways to begin incorporating those other disciplines into our model.
Would like to share with the Academy attendees at this meeting. Number one, thank you so much for joining us at Capital Caring Health's kind of booth. But also, I'm excited more than ever to kind of do home care medicine in the United States. I think our services and our skills for people who are even more concerned about getting out of their home and need high-level quality care at home with compassion and skill until the very end of life is more needed than ever. And both our clinical and business opportunities are only going to grow.